A very good evening to everyone. I'm Dr. Asna Ashraf, Joint Secretary of the Stillbirth Society of India, and it is my proud privilege to welcome all the esteemed dignitaries, the respected seniors, all learned colleagues, and dear friends to this webinar of the RPL Committee of the Stillbirth Society of India. I would like to begin the program by inviting our ever-energetic President, Dr. Neelam Agarwal, to give her welcome address. Neelam, ma'am.
Yeah, thank you, Asna. And good evening, everyone. So, esteemed Professor Ravi Chandran, Chairperson for today, and other faculty members, including Dr. Hemant Deshpande, Dr. Mandakini, Dr. Siddharth, Dr. Minakshi, Dr. Chanchal Singh, Dr. Shailaja, and Vice President of the Society, Stillbirth Society of India, Dr. Nusrat, Secretary Dr. Tamkin, Joint Secretaries Asna and Aisha, and Treasurer Dr. Nitika, and Recurrent Pregnancy Loss Committee Chairperson Dr. Shipra and Secretary Dr. Sujata, and all the delegates who have joined in and will be joining. I welcome you all to the webinar arranged by Recurrent Pregnancy Loss Committee of Stillbirth Society of India. And I congratulate Dr. Shipra and Dr. Sujata for their untiring efforts to put this together. And I must say that Dr. Sujata has been quite ill with dengue in the past few weeks, but still she has kept her commitment to be here today and a webinar in her capacity. So I welcome you all. This is a very important topic, recurrent pregnancy loss or recurrent miscarriages, as the definitions also vary across the countries and the nomenclature also varies across the countries. So it's a very challenging topic because it's very difficult to estimate the exact prevalence because of the varying definitions. And there are some challenges in the management also. But our today's esteemed faculty, I think, will be able to do justice to most of your questions and your queries. Thank you so much. With this, I hand over to Dr. Shipra to carry on the
Thank you, ma'am. I would now like to invite Dr. Tamkeen Khan, the Secretary of the Stillbirth Society, to introduce the RPL committee to us.
Thank you, Asna. Can I request Shipra to please start the slide sharing? Dr. Shipra, please. The slide share mode. So can you just yeah. Can you just go back to the second slide? Yeah. So it's my pleasure and a privilege for me as secretary to introduce Dr. Shipra and all the other committee members of the RPL committee. Dr. Shipra is my own dear student, and she's also a JNMCite. She's MD, FICOG, FMAS, MRCOG, and she's currently working as a consultant at Vedanta Hospital, Lucknow. She's an ex-professor and head Department of Obs and Gynae at the Iras Medical College, Lucknow. And her achievements are she's been a regional faculty. She has regional faculty certificate course in diabetes. And one of her areas of interest is GDM. I know that. She's been awarded Best Researcher of the Year 2017 by Indian Society of Hypertension, second best speaker in Speed Geeking session at midterm UPCOG 2016. And I remember that fun session and her wonderful way she conducted it. Best Paper Award in Gynae Oncology in AICOG 2020. She has more than 30 publications in national and international journals and contributed many chapters in books, and she's a very active member of the FOXY. The secretary of the society of the RPL committee is Dr. Sujata Sivaj. She is presently Associate Professor Obs and Gynae, PGI, Chandigarh. And so that is, I think, one of her greatest introductions. Her major achievements are she's MD, MPH, FICOG, FMAS, MAMS. She's been awarded the FICOG, the Fellowship of Indian College of Obs and Gynecologists, Dr. Jagdeshri Mishra Award for Best Posters on the theme of maternal fetal medicine in AICAG 2019. She has received a prize for oral presentation at the Current Opinion PCOS and Syndrome X conference. She has received first prize in gynecological oncology quiz conducted yearly by Obs and Gynae Society of North India in Ludhiana. More than 40 chapters to her credit and articles in journals. Her field of interest is, of course, stillbirths, high-risk pregnancy, public health in maternal and child health. And Dr. Shipra will introduce the rest of the members of the committee. So thank you very much for working so hard for this session, both of you. And now I hand it back to Dr. Shipra to conduct the proceedings. Dr. Shipra?
Yes, ma'am.
Yeah.
Yeah, I'm there, ma'am. So the members of the committee, we have Dr. Payal Saxena. She's the director of Srijan Fetal Medicine Center, and she's a fetal medicine expert. She is one of the members. The other member, Radhika Bajpai, she has contributed a lot to the RPL Society, and she's just now submitted to the newsletter as well. Dr. Radhika Bajpai is again a PDCC in fetal medicine, and she is presently working in Birla IVF. Dr. Aditi Agarwal, she is also one of the members of the RPL committee, and she's working as consultant in Apollo Medics Hospital, Lucknow, and she's also a fetal medicine expert. The last is Dr. Deepika Sharma. She's quite close to me. She has been a JNMCite, and she is presently the director of the ABG hospital in Hathras. So these are the 4 members of our team in the RPL. And from here, I'd like Nuzhat ma'am to introduce the chairperson for today's meeting. Nuzhat ma'am.
Thank you, Shipra. So a big thank you to Dr. Ravichandran. He's been a great support and a friend of mine for a long time. And professionally, he is the head of Obgyn Services Malaysia for the past 15 years under the Ministry of Health Malaysia, and has been responsible for a massive change in the obstetric services that they have, and looks after the services of the entire country. He also has the national registry, which has massive data, which has helped him bring about a lot of changes in the guidelines, and thus the care in Malaysia as such. He's also the chairman of the Confidential Inquiry into Maternal Deaths and the chairman of the Maternal Fetal Medicine Society. He is the obstetrician for the royal family, and if I remember well, 18 babies. And he's been our go-to person at Fernandez for difficult and rare cases. And I asked him whether he would be the chairperson for this, as he is a maternal fetal medicine specialist and is the president of the MFM Society in Malaysia. So with that, Ravi, a big thank you for agreeing to be a part of this over the next 1 hour. And we would like you to comment on the 2 cases, and would be very happy to hear your your opinion on how do you carry them in your country. And I give the mic across to you. Would you like to say hello to our small group over here? And it would be nice to introduce you. Thank you so much.
Okay. Very good evening. Thank you, Dr. Nuzhat, for those kind words. And thank you very much to the Stillbirth Society of India for inviting me to chair this session. I take this as an honor and privilege to be here and part of the team. I'm looking forward to the discussions and see how I can contribute. Thank you very much. I think we shall start without wasting much time. Thank you.
Thank you, sir. Thank you for being here. So we'll start today's session, and the first case will be discussed by Dr. Sujata, and Dr. Sujata's panelists are Dr. Chanchal. Dr. Chanchal is She's MBBS, MD, MRCOG, FICOG, and she is a fellow in maternal fetal medicine from Singapore. And she's Fetal Medicine Foundation UK accredited. She is the lead consultant in fetal medicine at the Madhukar Rainbow Children's Hospital, New Delhi. Her area of interest is antenatal screening, high-risk pregnancy, especially fetal growth restriction, multiple pregnancy, and fetal intervention. In her academic activities, she's the current member and past chairperson of AOGD, Fetal Medicine and Genetics Subcommittee, Editorial Board, Journal of Fetal Medicine, regular faculty at RCOG accredited academic programs and MRCOG exam courses. She is a regular organizer of CTG courses and FOGSI accredited ultrasound trainer at the current center, and has presented several papers and published several papers in peer-reviewed journals. Our second panelist is Dr. Minakshi Rohila. Her present designation is she's a professor in Obs and Gynae at PGI Chandigarh. Her major achievements include she's consultant in charge in recurrent pregnancy loss clinic, PGI Chandigarh, and faculty fellowship in high-risk pregnancy and perinatology. She is the editor of book Women with Recurrent Pregnancy Loss and Adverse Natal Outcomes. And she is a part of Pan-India PGI AIMS CDC network of HAI surveillance 2021. So she has many major achievements to her credit. She is well into academics with her publications of 60 research papers in index journals. She has 6 chapters in international books and 1 international book has also been published. Her field of interest includes surgical site infections, recurrent pregnancy loss, minimal invasive surgery, and infections. Our third panelist for the session is Dr. Shelter Singh, and she's the consultant maternal fetal medicine, Sparsh Maternal and Fetal Care Clinic, Muradabad. And she's again a JNMCite and has done DGO also from Aligarh. She is DNB from Command Hospital, Lucknow, and FNB high-risk pregnancy and perinatology, MAMC, Delhi. And she is, her area of interest is rheumatological disorders in pregnancy, and other academic achievements include executive member of Society of Fetal Medicine UP chapter, participated in various state and national level conferences as faculty, and she's contributed to chapters in books. So without wasting any more time, I'd like Dr. Sujata to start.
Very good evening to all of you. At the outset, I'd like to congratulate Madam Dr. Neelam Agarwal, Dr. Tamkin Khan, Dr. Nusrat, and Dr. Asna for their able leadership and their guidance. And I would like to extend my heartfelt thanks to Dr. Shupra Kunwar for all her efforts in organizing the webinar, as I was very recently suffering from dengue fever. And I'd like to welcome all our esteemed chairpersons and panelists. And I'd like to start the first case, which is a case of recurrent pregnancy losses in the first trimester. So our first case is a case of a 26-year-old lady who has come with previous 3 first trimester abortions, now had a spontaneous abortion at 7 weeks, and has come to the clinic with the products of conception. So the first question here is for Dr. Minakshi. Ma'am, what is recurrent pregnancy loss?
You asked the definition. It is, as you said in the beginning, it is the topic that starts with the controversies. The definition also starts with the controversies. As far as this has been decided, it's the failure of loss of pregnancy before the period of viability. Fetus reaches the period of viability. Regarding the recurrence, some society has said this is the twice, or some has said this is the minimum 3 pregnancy losses that has occurred. But as far as we talk about the recent agreement, it is the minimum 2 pregnancy losses that has occurred. Initially, it was by the RCOG, it was said that a minimum 3 pregnancy losses has to be there to call it as a RPL. but the recent American Society and the European Society also has agreed that if we say that it is a 2 loss or it is a previous 3 loss, the prognosis and the evaluation has to be same, and patient should be worked upon the same lines if she has a 2 loss or she has a 3 losses. This is if they have said that it is if it's around 29 to 30% chance of further subsequent losses if she has a 2 losses, and it is maybe it's around the similar rate, around 30 to 35% if she has previous 3 losses. So the evaluation, they have said it is almost same, and the women with 2 pregnancy losses should be considered in this RPL definition only. So
right. Thank you, ma'am. So the next question is, what are the causes of the recurrent miscarriages that we would like to consider in our patient? Dr. Shelja, please.
There are 3 consecutive first trimester losses. In these cases, our investigation will start from immunological causes like Anti-Phospholipid Antibody Syndrome, which accounts for around 50 to 20%. More importantly, we have a test as well as treatment for the condition. And it is the only cause of recurrent pregnancy loss that can be reduced. We have data around that it leads to improvement in the live birth rates. Second is, in our case, I'll find that since it is an early pregnancy loss, I like to do the genetic analysis. Also evaluation of the baby, that includes the sending the baby, I'll consider the genetic causes, that may be embryonic causes, that may include the aneuploidies like trisomy, especially 16, then other ploidies, triploidies, or monosomy of chromosome X that contributes to another 10%. Then there's a lot of interest in single gene disorder, but these are in still research purposes, but we know that almost 20 odd genes are involved in the single gene disorders are involved in the causation of recurrent pregnancy loss. Also, there's a lot of interest in going on in polygenic etiology as well as epigenetic changes. Coming on to the parental ones. The parental ones, we are concerned with balanced translocation, especially the reciprocal one, which accounts for more than 1/4 of the parental abnormalities, structural abnormalities. Then we have reciprocal inversions, and we have mosaicism and heteromorphism. Later on, since most of the guidelines mention uterine anomalies to be detected, which are positive in 50 to 20%, we look for congenital intrauterine uterine abnormalities, especially the septate uterus, because there is abnormality in the vascularity, and that affects the implantation. There is not much clear data regarding relating to this acquired uterine abnormalities like endometrial polyps, your submucosal fibroid, or intrauterine adhesions. And also, there is a subgroup with the cervical cervical weakness, which may be acquired one as a result of procedures that might have been done, like dilatation, curettage, or conization, or inherited one as a result of congenital uterine malformations. Then we have Thrombophilias, 8 to 12%, but in this case per se, since it is a first trimester loss, and we didn't get the history of any family history of or the personal history of any vascular event, thromboembolic event. So I'll not keep it in the first list, but definitely in case we need, the investigation would include the inherited thrombophilias like antithrombin 3, the factor 5 latent mutation, prothrombin mutations, and deficiencies of protein C and S. Right. Coming on to the last, infections also, they say that 5%, but we don't. Then rest 50% would be unexplained one. Even we search for all causes, but as we are getting in-depth knowledge of the genetic factors, might be this unexplained part will shrink later on, and we'll have answers to more recurrent pregnancy losses. Right. And lastly, the endocrine ones.
Right. Thank you, ma'am. So, ma'am, this question is for Dr. Minakshi. Ma'am, what history would we like from this patient and the couple?
Yeah, actually, this patient has come to us with a history of first trimester abortion mainly. So,
Yes.
I mean, before we start the evaluation, it is very important to start from the history. So, I mean, what about the details of the previous history? Was this pregnancy supervised? Was it a spontaneous conception? Whether she conceived on ART, or what was the detail of the pregnancy she had in the first? I mean, whether it was when she had an abortion, it was detected on ultrasound, whether the fetal heart was seen on the ultrasound, and she had a missed abortion after that, whether the disappearance of the fetal heart after it appeared on the ultrasound.
Yes, ma'am.
So what was the exact POG she lost her pregnancy,
Right.
and what was the type of abortion she had? Did she require any DNC? And does she, and the history, if she goes in other history also, it's very important to know her medical history also. Does she has any symptoms related to thyroid dysfunction? Does she has any symptom related to thyroid, I mean diabetes abnormalities, blood sugar abnormalities? Does she has
Yes.
any symptoms related to collagen vascular disease? Does she has any symptoms related to any chronic illness, I
Right.
mean related to recurrent pregnancy loss? In our examination, it is very important to see any features related to chronic illnesses or collagen vascular diseases, or any thyroid dysfunction, or any signs related to diabetes, or any other like she has is she already on some treatment? Whether she's many times a patient may not reveal you, but she may be having some medical treatment she's already on. Regarding the family history, it's very important for all of us to ask that whether she has still, I mean, has history of malformation child in the family, or she has already some detected genetic abnormality in herself or in the family. Does she has any history related to mental retardation in the family? So these things all make clinch towards the diagnosis that she may be, I mean, carrying a minor abnormality that is leading to recurrent pregnancy loss in herself. So this is about a history or an examination also. I mean, it's very important to examine her and see that whether it is some thyroid related, or in a genital examination also, whether she has some genetic structural abnormality on examination that may be the cause of her abortion. So exact POG and the type of abortion and any medical cause related to her abortion is very important to elicit in history and evaluation.
Sure, ma'am. Thank you for an extensive history. And in this patient, she's married for 2 years. Her menstrual cycles have been regular. All her conceptions have been spontaneous, and they've been confirmed early on by a urine pregnancy test. She's had all her miscarriages around 6 to 7 weeks of gestation, and she carries an ultrasound which shows a cardiac activity was present in the second pregnancy. However, there are no detailed fetal anomaly scans. That's the usual profile of patients that we get. She's had no medical illnesses and no family history of thrombophilias and diabetes. Her general physical examination, thyroid breast examination, and her abdomen and pelvic examination do not reveal any abnormality, and she has a BMI of 24. So the couple is eager to know the cause of the recurrent losses and have brought the aborted products of conception. So what investigations would you like to order for this couple, ma'am? Dr. Shelter, please.
Since this patient has already brought the POC along with them, so I'd like to send the POCs first in normal saline microarray. So because just micro has a better yield, there's more chances of getting a positive result. Culture failures are less, and there are less chances of maternal self-contamination. More so, although there are certain limitations of CMA, but then still it is better than karyotype. So most of the time we do it for the patients. Secondly, since they are 3 less than 10 weeks, so we can consider a testing for and strongly consider a testing for APLA.
Yes.
That includes the LSE, anti-cardiolipin antibodies, and also beta-2 glycoprotein, IgG and IgM. And this should be a persistent one. When we make a diagnosis, it should be a wholehearted effort. Like some people do just a LSE, somebody will do, because the diagnosis of LSE, this is more important than triple positivity or double positivity is more important. The titers has to be seen for all the three, and it should be persistent. Like these should be present almost for 12 weeks. TSH, we should aim at a TSH level that is around 2.5, HbA1c that is around 6.5%, and all the guidelines say that we must do a 3D ultrasound for these to know the anatomic causes. And this is a very, easily available investigation, I guess, most of the time, and easier to perform. Like it is just a click of button. And rest other investigations that we can do for these patients include
Ma'am, you extensively covered, I think, the investigations that we
for
need
most
to.
of the and if we don't find an answer in these, then we can further extend the workup for these patients. If we don't find the answers to our question in the first list, then we can extend it.
Sure.
Thrombophilias, DNA fragmentation study.
Right. So the next question is, what are the common genetic causes of recurrent pregnancy loss? And for this question, I'd like to ask Dr. Chanchal as to what does she think are the most common genetic causes of recurrent pregnancy loss, ma'am?
First of all, good evening, everyone, and thank you for having me on this eminent panel. So as Shalita just said that it would be good to do a microarray on the POC. However, when we are talking about recurrent pregnancy loss, I may find a chromosomal abnormality in that POC, and that would explain why the demise of that particular pregnancy happened. When we're talking about recurrent pregnancy loss, I need to know whether the parents are a carrier of a balanced translocation, which is the most common scenario. The chances of the percentage of the frequency or the chances that another pregnancy will result in a loss will depend on the type of the chromosome involved and the translocation that is there. So the most common cause is a balanced translocation in one of the partners when we talk about the genetic causes.
Right, ma'am. So genetic causes are usually the cytogenetic causes like aneuploidies or single gene, or they may be because of skewed X inactivation. And as ma'am mentioned, the balanced translocation in one of the partners can lead to, is the most common cause of genetic cause of recurrent
early pregnancy losses. Yeah,
yes,
early losses.
So ma'am, how do you think we should store the products of conception, and what are the genetics tests that we should offer to these patients?
So the POC is sent in saline, and we must make sure that we identify the villi before we send it. It's okay. If your lab is not in-house, you may want to add an antibiotic, which is mostly a gentamicin. And if suppose the patient has aborted and is come bleeding and you did a DNC at 12 o'clock in the night, then you can store the POC and saline in fridge, the normal fridge. And most of the labs currently are offering routine MCC on when they are doing the microarray on the POC. And as Shelter rightly mentioned, that because of the microarray, because when we order a karyotype, there is almost 50% will result in a culture failure, and we find it difficult to rule out MCC there. So the microarray has made it easier for us because the yield is more and one tends to pick up more information rather than the conventional karyotype.
Right, ma'am. So ma'am, but if the products, as we mentioned that we need to look for contamination, if the products are contaminated or degraded, then what is the next option for us?
So, I mean, we are talking about recurrent pregnancy loss. So the recurrence part will come from the partners. So what I'm interested is, even if I was not able to procure the POC or we did not do a genetic testing of the POC, a parental karyotype is recommended, not a parental microarray, a parental karyotype.
Right, ma'am. And so we take a blood sample in a heparin vial for the couple, and we have them tested for karyotype. So in our couple, the investigations are back, and we have a lupus anticoagulant, beta-2 glycoprotein, and ACLA, IgG, IgM, which are negative. Her thyroid and HbA1c are normal, and she also carries a 3D ultrasound from before, which shows a normal uterine cavity. And the CMA now done shows an aneuploidy in chromosome 16. So what do we do next? Dr.
We do a parental karyotype, and if that karyotype is normal, we reassure the couple. And if we do find a balanced translocation carrier, we counsel the parents accordingly.
Right.
But they have the option of, if she's a young girl, they can, I mean, they can, the best chance is to keep on trying, and eventually it will be okay because the risk is about 20 to 25%. And
Right.
they also have the option of, if we know that one of the parent is the balanced carrier of the parent's translocation, one can put, they do have the option of undergoing an IVF and doing a pre-implantation genetic diagnosis on the blastocyst. So those are the two options for them.
Thank you so much, ma'am. So the couple is very anxious and distressed, and rightly so. And they are very keen to know the cause of recurrent pregnancy loss and the chances of successful outcome. That's the reason why they visit the clinic.
Yes.
So the genetic counseling is very important in these patients. So how do you counsel these patients? This is for all the panelists. So first, I would like comments from Dr. Minakshi, followed by Dr. Shelja and Ma'am Dr. Chanchal.
Yeah, as you said, Sujata, I mean, as Dr. Chanchal also mentioned,
Yes,
this is, as you said, this is the aneuploidy in chromosomal 16, you said. Am I right?
Yes, ma'am.
So
Yes, ma'am.
it's right that we may need to check for this is an aneuploidy, and once the if the patient has aneuploidy, the chances of recurrence are not as high as in a condition when a parent is a carrier of a balanced translocation. So this in this case, the prognosis is better than if a fetus present with the unbalanced translocation situation. So we may counsel them, we may reassure them that this condition may not recur at all, and you still have the chances of having a live birth rate of about 60 to 70%. So we need to reassure them. But at the same time, if a couple really wants to, do not have a chance at all for this, that what are the chances, or does not want to have any risk of any recurrence, then obviously we have this option to have ART and then pre-genetic testing. So if at all, I mean, if you compare both the situations, that ART and versus spontaneous conception and the live birth rate, so still she has a very good chances of conception, though the chances of recurrence are much higher in a translocation carrier than a situation where the fetus presents with any cause of abortion as an aneuploidy. So I will reassure her that to have a good prognosis in the future as well in the case of this.
Thank you, ma'am.
That's all from my side.
Ma'am, Dr. Shelja, would you like to add anything more, or? Dr. Chanchal,
unmute yourself, Shelja. You have to unmute yourself.
So we have to also have an optimal state of health of the patient when we start about thinking about the next pregnancy. Lifestyle modification, changing the behaviors, like a lot of girls these days smoke, they have alcohol. So I mean, these obesity is again a problem. So we should have aim at achieving an optimal health. Then we'll go for, as ma'am has already summed up, like for numeric aneuploidy, the recurrence rate is just 1% for most of them, and only if there is carrier status in the parents, then only the risk of having abnormalities in the recurrence in the fetus, that too is only 30-40%. So the overall chances are good.
Right.
So, I mean, just to, everybody has already given their inputs. I think it's very important to tell these couples that however distressing the situation is, only 2 to 5% of healthy couples will have this problem. And when we embark on this journey of testing across these 4 common causes that you have enumerated, we will find a cause only in 48%. And in the remaining, in whom we do not find a cause, the chances of having a healthy live birth is similar to any other couple. So that becomes very reassuring for us, for the parents also. And this option of pre-implantation PGD is only when I know a prior, I mean, I hope we are not confusing. So there is one couple in whom we did not find any cause. The POC showed trisomy 16, but the parental karyotype is normal. I would reassure them and ask them to conceive spontaneously. However, if there have been recurrent losses, because it becomes very distressing for them, and if there is a balanced translocation in one of the parent, then only do we talk about IVF PGD as an option. They still have that option of trying to conceive spontaneously, and they'll just get lucky.
Right. I would also like to ask Dr. Ravichandran, our expert, sir, what is your take on pre-implantation genetic testing and the experience you have in from your country?
All right. Okay. I think it's a quite interesting case, but I think there are a few things here that we would like to, take into consideration as well before I go into PGD. This lady is 26 years old. Her BMI is about 24. She got pregnant 3 times within 2 years. I think that's a little close, the proximity. And the other thing in the history that I wanted to know was there any history of consanguinity in the family? Are they related in any way? Are they first cousins, anything like that? Because it's quite common in Indian families to have some degree of consanguinity. And the third thing was the question of PGD. Now, the PGD is available here in Malaysia, but it is not offered within the public sector, meaning the Ministry of Health doesn't offer PGD. So it's only available in the private sector, and it is quite costly. So sometimes when we have this recurrent pregnancy loss patients and we think that they will benefit from this PGD, what we do is we actually get a private center to come involved, but we will subsidize the IVF part of it, but not the PGD part of it, because it can be quite expensive. So that is not in the domain of the public service provision in Malaysia, but in the private sector, yes, it is widely available. It's widely available. And the other thing that would be interesting in the history would be, although we found that this to be something that is, something that we hope is not recurrence, because we feel the recurrence is in the region of 1% or less, but nevertheless, it'll be interesting to know if at either side of the family, the male as well as the female, whether in their family itself, they have any history of such recurrent pregnancy losses or even stillbirth, which again may alert us to something that we may not have actually seen. I think this is something that we can always consider. Thank you.
Thank you, sir. Thank you so much. And I hope with all this counseling and all the information that we have gathered, we will definitely help the couple and to achieve a good pregnancy outcome. And now I'd like to hand over to Dr. Shipra Kunwar for the second case, ma'am. Thank you.
We'll start with the second case, and I'd like to introduce Dr. Siddharth Das, who's a professor and head at Eras Lucknow Medical College in Rheumatology Department.
Yes.
28-year-old female. She's para.
Any other degree in the past that will make it a recurrent one. So this patient will need further treatment. More so, it is also important, like how much time did the patient take the treatment? Because might be she has not completed her treatment. She might be at risk of having another. So, might be we need to start her again on anticoagulants. So we'll look for the same. Again, I'll ask the family history of the patient, like if there is history of having family history of patients, the sites of embolism, any younger age group member of the family involved, and that's it for this patient.
Okay, so the basic.
Along with this, also there are certain other features that I like to ask, like since many of the for if I'm thinking of APLA, it has an association with SLE also. So I like to ask the history of any history of breathlessness, any joint pain along with it. So history related to APLA, the generalized examination, any history of alopecia. What other workups has been done? And if possible, was this placenta? We don't know where did she deliver. So was the placenta was sent for anything for any histopathology? Did we get any finding from histopath of the placenta? Many other questions that I like to ask regarding the pregnancy per se. and also importantly for the patient's point of view. It's not only about the pregnancy, but we don't know whether she has stopped in just 10 days of taking a warfarin. So might be we need to put her again on anti. I mean, that's it.
Okay. So this patient, the records were very sketchy, and she only came with a history from a hospital that she was admitted with DVT and put on a heparin and later discharged on Warfarin. I'll ask Dr. Minakshi, now that this patient has come to you, how will you further investigate this patient?
So you have already given a strong clue about the diagnosis in this patient. Though I would still like to investigate her online, apart from the testing for the antiphospholipid antibody syndrome. We have a very specific criteria, and we need to have one clinical criteria, and we need to have one lab criteria. So for clinical criteria, she fits in one of the criteria that shows that if there is a unexplained loss of any fetus, morphologically normal fetus after 10 weeks of period of gestation. So she fits into that clinical criteria. The other clinical criteria are first 3 trimester pregnancy losses and or any other loss before 34 weeks of pregnancy with hypertension related or IUGR related cause. So these are 3 clinical criteria. In one of these patient actually fits, and the other lab criteria are the testing for lupus anticoagulant, antiphospholipid and anticardiolipin antibodies, and beta-2 glycoprotein. Both IgM and IgG have to be checked, and the titer has to be in moderate to high titer positive. And if it is positive, then it has to be checked twice at the gap of 12 weeks. So these are the criteria that we have. These are the testing for antiphospholipid antibody syndrome, and the rest I need to see for the blood sugar or blood sugars also in this woman. I would like to do GTT also in this woman to know if any other cause is there, though the history of DVT is very, clicks towards the diagnosis of antiphospholipid antibody syndrome, but I would like to do to check the sugars and thyroid function test also in this woman. So that's about is this. And apart from these 2 and routine testing like complete hemogram, blood group, PDRL, and other tests of the pregnancy, I would postpone the inherited thrombophilia testing for the next step. If all other tests are negative, then only I will go for the testing for the inherited thrombophilia. The other societies and other recommending bodies also suggest that these should be the investigation, especially in a woman who has presented with the DVT and with this history. If these all tests are negative, then I may think of doing further testing. That's all.
So anybody can like to add to this, whether thrombophilia testing should be done or it should be postponed for this time?
Already venous thromboembolism was there.
Yes, yes, yes.
It's very simple.
Okay.
You can
Yes, sir.
continue.
Okay. So Dr. Minakshi, can you tell us why we need to do it at 12 weeks, this antiphospholipid antibody testing to be repeated at 12 weeks? Is there any justification for that?
Basically, there are there may be other causes also for these positivity. So to rule out these false positive cases also, we need to check it twice, and that too in a moderate to high titer positive. There are certain conditions like chronic infections also where the antibodies may be present, that we need to see that is why we do it twice and to call it as a positive test. The only once testing may not be justified to start her on treatment, though the recently some rheumatological societies has suggested that there is a role of some other antibodies also. If you have a very strong doubt and you do not have the APLA positivity, or but you have a very strong clinical suspicion, you should test for the other antibodies also. And these are the non-criteria APL also. But still, I would go for the basic testing first, then only I will go ahead with the next step of the testing. So in a woman who has come with a history of DVT, if she comes in a non-pregnant period, then she may be, she may need a workup for the DVT, complete workup for the DVT also. That includes the inherited thrombophilia testing also. But if she comes into the pregnancy, I would still go for the testing of antiphospholipid antibody syndrome first, and then I will go for the testing for the inherited thrombophilia, because that's a costly test, and it's not valid in the pregnancy, most of the tests, except the mutation parts. That's all from my side.
Thank you, Dr. Minakshi. And that was very well said. So interpretation of positive results of APLA is very, very important. A clinically significant antiphospholipid profile is seen as presence of one or more of the APLs on 2 or more equations, at least 12 weeks apart. And the test, that is the Lupus anticoagulant test, is based on the guidelines of International Society of Thrombosis and Hemostasis. And it could be dilute Russell Viper venom testing or by APTT testing. The ACL, we need to do IgG or IgM, and with a titer of more than 40 units should be considered as positive. And anti-beta-2 glycoprotein, IgG, IgM, again with a titer of more than 40 units should be considered as a positive result. So, but somehow she was also, worked up, and she tested positive for ANA, that is anti-nuclear antibodies. Now, as obstetricians, we are very confused as to how to proceed with an ANA positive. So I will request Das sir to tell us how should we interpret this ANA positive which was done in this patient.
Thank you, Shipra. The anti-nuclear antibody test is generally done by 2 methods. When you send an anti-nuclear antibody test to a lab, they are likely to do it by an ELISA test, which we discount totally and say it has no reliability or validity. The other test is the immunofluorescence test, which has been, slides are shown here of an immunofluorescence test. And this test is supposed to be a good test. It takes the whole nucleus as the antigen. And generally, the antigen that is used is the HEP2 cells, which are used in this. These are kidney cells. And these HEP2 cells are supposed to be the best for doing anti-nuclear antibody tests. The test comes in multiple, there can be very different patterns when you see under a fluorescent microscope. The most commonly seen is homogeneous pattern and a coarse linked speckled pattern that is seen in systemic lupus. But other may be seen, but these are generally not pathognomic of systemic lupus, whereas these are quite pathognomic for lupus, systemic lupus. So generally, we would like to look for homologous, homogeneous ANAs and coarse speckled pattern. So if you get an ELISA test, discount it totally. There are 2 more problems with this test. This test is common in about 15% of the healthy individuals. And prevalence of SLE may be at best maybe 0.1% of the population. So for 150 people in the population, there would be 1 SLE patient who has an SLE out of those tests, which are 150 persons have SLE, ANA positivity, only 1 of it would be SLE. So these tests are good for excluding SLE, not 100%. That if it is negative, then you would say that chances that this is SLE are, it is not SLE, but if it is positive, it doesn't mean it is SLE. So you have to see for other tests. Other tests that can be done for this, for looking for this, one is anti-Smith antibody, one is anti-dsDNA antibody, and this can be done by looking at ENA test. ENA test is extractable nuclear antigen test, and in this Generally, we get a line essay. You can get a line essay done in which there are lines which appear, and then each line would represent that this is for this antigen, this is for this antigen, this is for this antigen, and you can assess that. Generally, in those, anti-dsDNA can be seen, and antihistone can also be seen, which is not given in this slide but would come up. Antihistone, which is written here, is not seen, but sometimes in some of the DNA panels it is there, in some of the panels it is not there. So this you may have to get done separately if it is not there in the panel, but if it is there in the panel, so you get reports of antihistone. Antihistone antibodies are generally seen as drug-induced lupus, and anti-dsDNA antibodies are quite pathognomic for lupus nephritis, which has a very severe and a poor prognosis. If they are present, would indicate lupus nephritis, and lupus nephritis in pregnancy is pretty bad. You cannot treat it well also, and it also is one of the reasons for very high fetal mortality and even maternal mortality. So we don't want to have that. So this is generally the thing which happens. So we can have a number of things in this. When we look at systemic lupus, we have this is a SLIC classification. This is a new classification that has come up. Initially, the old classification had only 11 points in total, of which 4 had to be positive. Now it is 11 plus 6, that makes it 17. And out of these 17, 4 have to be positive for making a diagnosis of systemic lupus. Skin lesions of different varieties, oral and nasal ulcers, non-scarring alopecia, arthritis, serositis, renal involvement, which is generally seen in the form of a urine examination. Serositis may be seen clinically or on ultrasound, but kidneys are generally seen on a urine examination or serum creatinine. Then hemolytic anemia is, of course, a diagnosis which is made on investigations. Leukopenia and thrombocytopenia is also there. Now, if you look at this particular patient, this patient did not have many clinical features, but these things were not looked at. Hemolytic anemia, leukopenia, thrombocytopenia, or a urine examination was done, or any of these tests were done. So the patient would not classically fit into a systemic lupus since it was not fully investigated for systemic lupus. The reason, can I have the next slide, please? The reason why we would like to do antiphospholipid, the ANA in patients with antiphospholipid antibody syndrome. Please don't change slides.
Sorry,
yeah, this one. So the antiphospholipid and antibody syndrome was first detected in patients with SLE. False positive VDRL test is frequently seen in patients of SLE and was in the criteria for SLE earlier. Now it has been given up. False positive VDRL test was more often associated with thrombosis and also with fetal losses. That's why you still do a VDRL test. Among the thrombotic patients, coagulation tests were, when in thrombotic patients coagulation tests were done, it was found that there is an increased APTT suggesting presence of an anticoagulant. And this was called as lupus anticoagulant, that there is an anticoagulant present, but it leads to thrombosis. And this is what is lupus anticoagulant, or LAC, whichever way you would like to use a short form. Antiphospholipid antibody tests and VDRL both have phospholipids, use phospholipids. In VDRL, it is cardiolipin. Otherwise, we use phospholipids in the various tests. As a result, this antigen was postulated that from this it was postulated there are antibodies to phospholipids in patients with SLE, and that's how it came up into the current classification, that you do a anti-cardiolipin antibody test or test for antiphospholipid antibody syndrome and would be taken as a manifestation. VDRL is no longer there.
Okay, sir. So this patient was evaluated by the rheumatologist, and as is already saying that the SLE was considered unlikely because none of the patient did not have any clinical criteria.
No clinical features, so very unlikely. But yes, we need to do investigation to say whether it was there or it was not there.
However, she was antiphospholipid antibody positive on 2 occasions, 12 weeks apart. So I would request Dr. Chanchal to mention what should be the plan of pregnancy for this patient.
So going by the history and the whatever we've concluded from the investigations, this lady does have antiphospholipid syndrome, and we would want to, as a pre-pregnancy workup, we would want to check her renal function, ensure that she has not developed hypertension, and the role of anti-Ro-Antila, I don't think there's much role of anti-Ro-Antila here, just because her ANA was positive, because there's a lot of overlapping spectrum. I think this is antiphospholipid syndrome, and we should take it from there. Try to minimize any contributory morbidity factors, which includes, as I said, hypertension, deranged renal function, and do a baseline CBC. Ensure that her BMI is, if she has a high BMI, then give her lifestyle and dietary advice so that the BMI is in control. And one would want to counsel her that, pre-pregnancy counseling, that it would be a high-risk pregnancy. She would need more frequent antenatal visits. She would need anticoagulation with low molecular weight heparin, both antenatally as well as postnatally, and then make a plan. That's how we would go about it.
Okay, so what interventions can be added, and how would you monitor this pregnancy?
So this patient needs to be monitored in conjunction with a physician. That is, it is a high-risk pregnancy. Once the urine pregnancy is positive, one would want to put her on aspirin, and even the RCOG, because it is an antiphospholipid syndrome with the previous venous thromboembolism in the last pregnancy. So as soon as she's pregnant, she should be put on low molecular weight heparin, both for thromboprophylaxis as well as to prevent any pregnancy-related adverse outcome. She should undergo a first trimester screening, as is usual for all pregnant women. She should be on continuous BP monitoring. Urine routine should be checked at every visit. As I emphasized, that she would have more frequent visits. From a fetal surveillance point of view, she would need an antenatal anomaly scan at around 20 weeks. None of these medications would have it increase the chances of having an anomaly. So it's not from that point of view, unless you said that she had stopped Warfarin earlier, right? She was not on Warfarin. Yeah. And from the late second trimester and early third trimester, she would need 4 weekly ultrasound surveillance, which includes monitoring the growth as well as the fetal Dopplers. And beyond 32 weeks, the frequency of ultrasound would be according at least 4 weekly, more frequent monitoring as per her blood pressure status, as per her the growth charts and the Dopplers of the current pregnancy, with an aim to go as close to term as possible.
Yeah. Thank you so much. And for aspirin, I'd like Dr. Shailja, if he can just tell us what dose, when to start, what should be the duration, and what about LMWH, the dose and duration in this patient especially.
So in this patient, since this is an APLA positive patient with a DVT, APLA with a DVT comes under very high risk for DVT in the next pregnancy, thromboembolic event in the next pregnancy. The low molecular weight heparin for these patients should be started all through the pregnancy, as soon as the pregnancy is confirmed by a cardiac activity. Aspirin we have to start when she's trying for preconceptionally, and that has to be given in a dose of 75 to 100. But with a catch here that for most of the guidelines that we have been using and for others, they said we use 150 milligrams of aspirin for reducing the risk of preeclampsia. So it would be better to start at 150 milligrams of ecospirin conceptually, and then put her on a low molecular weight heparin, the therapeutic dose of heparin, all through a pregnancy, right from the point where the cardiac activity was documented till she delivers. And before delivery, 24 hours before delivery, we'll stop it. And then postnat, if she is going to deliver by a cesarean, and postnatally, postpartum also for 6 weeks. Because once a DVT, the patient has to receive thromboprophylaxis for all through the pregnancy and postpartum prophylaxis also. Second point, I'll come back again a step later, that we didn't do a thrombophilia profile in this patient, I guess, just because we don't know whether it was an acute event. We'd never do a thrombophilia profile in an acute setting. It should be a difference of 3 to 6 months before we order a thrombophilia. And also we normally don't order all the thrombophilias, like, because once we are anyways going to give her a anticoagulant prophylaxis. So even if we are going to test for thrombophilia, we should test for the high risk thrombophilias like antithrombin 3, compound hydrozygosities, or thrombin, or factor 5 homozyte.
Here, Shelter, thrombophilias, we have actually, we didn't test because this was one single episode of DVT. So that is why, but it's a plus minus. You can or you may not test for that.
But definitely not all the things should be tested, because anyways we are going to give. So lesser common ones like protein C, S should not be tested, the higher risk one, that we can decide on what dose of prophylaxis we have to give the next pregnancy, like therapeutic or prophylactic.
This patient has antiphospholipid.
Yeah, that's it.
Along with, and she has a history of previous thrombosis. So in this patient would require long-term anticoagulation, and not only for 6 weeks. And she would require warfarin for as a long time anticoagulation. I will request Ravichandran sir, so if he could add into something on the management of this patient, and especially the dose of aspirin, and how LMWH should be given in these patients.
Right. Okay. I mean, this is a very interesting case, and in our practice, we tend to give 150 milligrams of aspirin, preferably a night dose, and our normal low molecular weight that we normally use in our practice is Clexane, actually, and we use about 40 milligrams depending on the weight at times. And but in our practice, we do not continue with aspirin postnatally. We stop the aspirin at delivery. In fact, at 36 weeks, we tend to stop. And postnatally, we would usually cover them with low molecular weight heparin. And if there's cost issues, then we look at heparin itself. And at 6 weeks, we will actually reassess them to see whether we need to continue them with warfarin or not for another 3 months. So this decision is actually made together with the rheumatology team rather than us. And in this patient, I think from the history, it looks like there's a family history as well as there is a pregnancy-provoked thrombosis there that we see in the history that ended up with the intrauterine death. Then I think the need for us to do thrombophilia screening for inherited thrombophilia screening, I think would be justified. It would be justified. But I would like to know from you all, is it standard practice to continue aspirin postnatally?
No, sir.
No. We stop after delivery. Before delivery only we stop.
Yeah, but you see in the table there, cesarean section, prophylactic dose and low dose aspirin for 6 weeks. That is something which we don't, I don't practice actually. Maybe I must learn something new. But
we also don't practice, sir.
Dr. Ravichandran.
Yes.
If I may intercede here.
Sure.
papers say that yes, and there is a review paper which came out in 2020, in which they have very clearly said that yes, use warfarin for the rest of the life. Primarily for the reason because 17% patients die because of thrombotic problems. So it's better to give them heparin throughout life.
Yes.
And they have low dose heparin, but they have not talked of aspirin throughout.
Yes.
Yeah.
Warfarin,
Yes,
I agree with you.
after the
That's
delivery.
outlet.
We don't
Yeah.
continue.
We don't continue.
I
Yes.
think Dr. Shipra, there is one more important thing is
Yes,
the
sir.
patient's education about how to take low molecular weight heparin injection.
Yeah.
This is one of the most important things. She cannot come every day to your clinic and take the injection.
Yes.
She should be educated how to take it, where to take it, and that's what is more important thing. And what type of needle she should use for taking the injection. So we must educate our patients that she should take heparin, low molecular weight heparin, either 40 or 60 milligram, depending on weight of the patient. Usually what we follow, if the weight is less than 50 kg, we give 40 milligram heparin, low molecular weight heparin. If it is more than 50 kg, we give 60 milligram. It comes approximately 0.4 ml for 40 mg and 0.6 ml for 60 mg. It's very meager dose. She has to use preferably a heparin syringe if available. There are injections available which are pre-filled one. Otherwise, she can use a very well insulin syringe for giving this particular dose. If she is educated well, the needle what we are using for giving this injection is 26 gauge, and the length of the needle ranges between 5 millimeter to 10 millimeter. And this is the sufficient one can be given for subcutaneously. She has to give it over the thigh anterior aspect, or she has to give it over the abdomen by the side of belly button on either side in the early pregnancy period. Later on, she can't give it. I do agree. But in early pregnancy, definitely she can give it. So cleaning properly the area, hand sanitization properly, filling the proper dose, 0.4 ml and 0.6 ml, she can very well learn. It is very simple. Pinch the subcutaneous tissue properly, lift it up and pierce the needle either by 45 degree or 90 degree so that she is not reaching the muscle. Important, heparin is not absorbed in muscles. Remember, it has to be absorbed in subcutaneous tissue only. So educate the patient properly for taking the injection of low molecular weight heparin is the first priority of the treating obstetrician in the OPD before you prescribe the patient low molecular weight heparin to her. I think this is one of the important tidbit, and sir has rightly told, aspirin, we always prescribe in 150 milligram. We don't give 75 milligram. And it has to be taken at bedtime. It has to be taken either with meal or after meal.
Yeah.
So that's the precaution the patient, and it has to be taken perfectly at that time only.
Yeah.
A regularity in maintaining low dose aspirin is one of the most important thing. 150 mg at bedtime. You tell the patient that she should not miss the doses. That is more important.
Yes.
So some education is mandatory when we get such type of patients. Health education of the patient, injection, how to take low molecular weight heparin injection, how to take low dose aspirin tablet. All these things are to be told properly to the patient, and this is one of the important things. I think over to you, Shipra. Please continue.
Thank you so much, sir.
And one more important thing, Dr. Shipra.
Yes,
low
sir.
molecular weight heparin should not be kept in freeze. It should not be kept in freeze. It has to be kept on the shelf. It's a room temperature drug. You are not supposed to keep low molecular weight heparin in freeze, because many times patient is having idea that injection given by doctor to be kept in freeze. So that also you have to tell her.
Right.
Dr. Shipra, just a reminder for we should finish in time.
Yeah,
Yes.
yeah, madam. We know.
Okay. So this is the last slide. So you should have a multidisciplinary approach to management of such patients, include a rheumatologist, a physician in your management of the patient. Antiphospholipid antibody tests need to be repeated, and only they are positive if they are positive on 2 occasions 12 weeks apart. And test interpretation is also very important. Aspirin and low molecular weight heparin, they increase the live birth rates in patients with antiphospholipid antibody positivity, and those with a previous thrombosis, a therapeutic dose of LMWH may be required, and these may also require long-term anticoagulation, and this should be taken into consideration only with the once in conversation with a rheumatologist. Thank you so much for your patient hearing.
Thank you.
Thank you all the panelists.
Thank you, Shipra. Thank you, everyone.
Right. And thank you, Dr. Ravichandran, for
just the last thing to add. I think if this patient is on long-term warfarin and she plans to get pregnant again, then she should attend a preconception clinic to get a warfarin converted to a low molecular weight or a heparin prior to embarking on the next pregnancy.
Before she conceives.
Yeah, because she will be on long-term warfarin, and it has to be thought, if she plans to get pregnant, it has to be planned. I think that's something to keep at the back of our mind.
Yes, sir.
Yes.
So,
Yes.
regarding this low molecular weight, low dose aspirin, this table I've taken from Up to Date, and they have mentioned that it has to be given in the even after postpartum. So that is
we need to look into it. Yeah.
well, because we are not giving it postpartum.
The RCOG does not recommend it.
Yeah,
RCOG
but something interesting to think about.
Yes. Yes.
Yeah. True.
Thank you.
Thank you so much.
Thank you.
I'm really thankful to Dr. Ravichandran because of the time difference between, it's almost 11, I think, 11 p.m. in Malaysia right now.
This is my most active time.
Okay, thank you so much.
Thank you. Thank you very much.
So we'll start with the next part, and there are 2 small sessions. First is by Dr. Mandakini.
Please share this.
She's a professor at SGPGI Lucknow, and we all know she's also currently the chairperson of the genetics. Sorry?
Medical genetics.
Medical genetics. And she's doing a lot of work in educating all of us and sensitizing all of us regarding genetic causes of bad pregnancy outcome. And she's done a lot of work on Rh negative pregnancies.
Great.
Thank you so much. Thank you for all these all those kind words. I enjoyed the previous cases and hope I will hear. I'm looking forward. I thought sir will speak before me, but then you asked me to speak before him. So anyway, let me go on to the topic. So next 10 minutes, I'll be going through what is the genetic cause in recurrent abortion, some of which you have discussed already and have made my things easy. Genetics, thinking about it, earlier we used to run away and thinking about genetic counseling, some sonograph, some test, genetic screen, cell-free DNA, familiar cancer, it goes on and on. But the things are changing very fast. And what I can understand is we have started looking into the genetic causes and we have started knowing about it and trying to figure out what we need to know as an obstetrician or a gynecologist. So this talk of mine will, at the end of it, you will be knowing something about chromosomal abnormality and a word about inherited thrombophilia. I have not rest on it, as this thing says. And this is my most favorite slide, that which says that lines makes pages and pages makes books, and book, if we start them together, that is book rack. And that we know that alphabets making words, lines, page, book, and book rack. And what is called as the nucleotides or ATGC, 3 of them forms a codon which codes for an amino acid, and multiple amino acids form a protein or one gene. So one gene codes for one single protein which consists of very different amino acids, and multiple proteins or multiple genes are packed together to form a chromosome. So if we are talking about one single chromosome, then that consists of multiple genes that is together. So if you can't read this, what I have ABCD I have written. If I can read it out, like I can separate it out, then I can know that I want to read genetics. And similarly, we have got ATGC all written, and they are triplet in number, or 3 of them codes for one amino acid, like one codes for one another amino acid, and AA 3 and 4, and they are put together forms a protein. So this is our basic concept of genetics, which carries us forward to understand what we are dealing with and what we are talking about. So always I am fond of making these 2-3 slides and have repeated several times. So our background knowledge from class 10th, class 12th is human cell has got 46 chromosomes and 44 are autosomes, 2 are sex chromosomes, XX and XY. And if I depict them, they look something the book rack arranged in a library. If they are arranged like this, you can't make out anything. But if I will go and try to arrange something like this, then you can make out something where is anatomy, where is physiology, and where is obstetrics, and you can look for it. So similarly, in a cell, the chromosomes are arranged very haphazardly, and under a microscope, they are arranged so that we can read it and then report it. And what is called as a karyotype. So chromosomal analysis, or otherwise known as karyotype. And there are these things, sex chromosomes, which are either XX or XY. And then identifying them, we number them as 1 to 22, and then the sex chromosomes pair. So and what is chromosomal abnormalities? Number can be abnormal, and here a chromosome 21 is an addition, so it is called as a trisomy 21, or similarly 18 can be an extra 18, or 13 can be extra 13, what we call as trisomy 21, 18 or 30. And we may detect in spontaneous abortion cases, antenatally screening, all of us now are fond of doing this, screening, double marker quadruple test or NIPT, and then in a stillbirth, this was recent, this thing. So came with high drops and died, and this thing was diagnosed to be trisomy 21. Maybe in an adult or a mother couple comes with previous baby with trisomy 21. Similarly, trisomy 18 are diagnosed with multiple malformation, and 13 may be hollow prosencephaly, or sometimes you may deliver like this, this thing. And you can see that the chromosomes may be 1 extra in chromosome 13. Sometimes you see every chromosome 3 in number, or all book rack, extra rack in the whole of the library, or it is 69 chromosomes, which is called as a triploidy. So please remember, what is trisomy is 1 extra chromosome, whereas triploidy is the whole set is abnormal. Hence, sometimes you get a report of trisomy 18 for FIS for chromosome 21 is 3, FIS for chromosome 18 is 3, FIS for chromosome 13 is 3. So you need to infer that all chromosomes are 3 in number, and that is 69 chromosomes, which is a partial mole or a triploidy, and you sometimes deliver. Now coming on to recurrent abortion. So this is a couple who presented with us with previous 5 abortions. So you try to, as discussed earlier, we try to do the karyotype or chromosomal analysis of this couple, husband and wife. Always try to do together so that you can infer. Sometimes what happens is the lab sends report at different time. We forget who is the wife, whose husband is whose wife. So it's a little difficult. So please be careful about it. And this is the result has come as T. There are 46 chromosomes. So, and it is XX. That means wife is the carrier. T stands for translocation. And this 4 and 12, please do not confuse about it. And this is very simple to understand, that there is a translocation between chromosome 4 and 12. And this Q and Q stands for, Q means longer, and Q, we stand on a Q, it's a long. So if it is easy to remember, Q stands for longer. So Q is Q of 4, and the second denotation is for chromosome, the next chromosome, that is 12. So long arm of 12 and long arm of 4, there is an exchange or translocation between these 2 chromosomes. So please do not get this thing worried about what is this report. So the wife is a carrier of chromosomal translocation, that is between chromosome 4 and chromosome 12. So it can be a translocation. There is no loss or gain of genetic material, and hence it is called balanced. So there is no loss or any gain in this. But if there is a large deletion or a duplication of part of the chromosome, then it becomes unbalanced, and this individual will have some amount of symptoms. This unbalanced will have some amount of mental subnormality or malformation or anything. So usually in recurrent abortion, what we expect is, we expect a balanced chromosomal translocation, carrier of a balanced translocation in the couple. So coming back to this, this thing, chromosomal rearrangement, that is between 2 and chromosome 10. That is translocation between chromosome 2 and 10. I will go little deep into what will happen to the gametes in this case. So you can see there are exchange of books, but there is no loss or gain of extra books in this library. So this individual is a balanced carrier. So now what will happen? In gamatogenesis, we know that 23 chromosomes will go to one gamete and 23 in another gamete. So every gamete has got 23 chromosomes. And here I've represented them in a normal setting. There will be normal 23 in the gametes. But what will happen if there is a translocation between chromosome 2 and 10? That was our previous case. So one possibility is that both the normal 2 and 10 goes to one gamete, and the both translocated gametes goes to another gamete. So this becomes a balanced carrier gamete, and the outcome will be, and rest of the chromosomes are same. So these two, previous example of balanced carrier will result in a normal pregnancy outcome. And this, of course, is a normal gamete, and hence a normal pregnancy outcome is expected. But what will happen if there is one is normal and another is translocated ones? So this portion of that chromosome is double in amount, and one will come from the other partner. Then there will be partial trisomy of this portion, and the other chromosome, that is chromosome 2, this portion, the lower portion, is missing. So hence this is called unbalanced gametes, and the other way around in the other chromosome. So this unbalanced gamete will produce, it results in abortion, malformation, or retardation. So this will be the outcome in translocation carrier, and this is between two autosomes, and between these two are called as a reciprocal translocation. Whereas if these are between two acrocentric chromosomes, which are 13, 14, 15, 21, 22, then it is called Robertsonian translocation. These chromosomes do not have a PR or a short arm. They have got only the long arm. So what has happened is, this 13 to 13, it would have been 214. Instead of 214, 114 has gone and got attached over 13. So the 13, 14 is attached to each other, one of them. So here it is 4 and 12 translocation, that is reciprocal translocation. Whereas in Robertsonian translocation, what happen is, the lab gives you a report. So the total count of the chromosomes will be 45, because one of them has gone and got attached to here, and we count them as single, is 1. So in counting, it will be 45, because Y chromosome, so XY, but ROB stands for Robertsonian translocation between chromosome 13 and 14. So this is an example of Robertsonian translocation between chromosome 13, 14, and there can be a Robertsonian translocation between chromosome, same chromosome, that is 21, 21. It may be 13, 13. It may be 14, 14. So these are Robertsonian translocation, and then the lab reports you as ROB. Now coming on to this 14-21 translocation, this is what I have represented in that lab, this thing, book depiction. There are 14 and 121 has gone and got attached over here. So in counting, there will be total of 45 chromosome and a Robertsonian translocation between 14 and 21. So this 21 has gone and got attached with the 14. So what will happen to the gametes? There will be either both the normal 14-21 into one gamete and this translocated into one gamete, and this is a balanced carrier. The outcome will be normal. Whereas if it receives 241 and one that attached one, so this will be 240. So the product will be trisomy 14, and here this will be monosomy 14. So there is no 14 in this gamete. So definitely these will result in spontaneous abortion. So, and if there are, say, 14 and 21 in one gamete, and the other partner will contribute to 1, 14 and 21, which are normal. So will result in a normal, absolutely a normal individual.
Ready, don't turn off your computer.
Okay, so balanced carrier can result in because of 14-21 translocated, and this results in a unbalanced gamete formation or unbalanced fetal embryogenesis, and hence this will result in spontaneous abortion or trisomy 21 if it is these 3 copies of chromosome 21. Coming on to 21-21 translocation, which is the most important thing that we must remember is there are 2 21 which got attached one over the other. The same chromosomes are involved. And what will happen in gametogenesis? You will have either both the 21 in one gamete and the other gamete doesn't receive any 21. So it is nullisomy for 21 and 1 will be added from the other partner. So it will have monosomy 21 that results in spontaneous abortion or trisomy 21. So all gametes will be unbalanced and hence all fetuses will be affected with either trisomy 21 or spontaneous abortion. So see the difference between different chromosome translocation of Robertsonian is 14-21. The recurrence risk or abnormal pregnancy outcome maximum is 10%. Of course, it depends on the couple who is a carrier. And whereas if it involves the same chromosome, the recurrence risk or abnormal pregnancy outcome is 100%. Here is the role of gamete donation. So we must remember that if it involves 2 same chromosome, then the abnormal outcome is 100%. There only, that is the condition where you want IVF with a donor gamete or IUI with a donor gamete, whatever the case may be. So the outcome will be normal, balanced carrier, recurrent spontaneous abortion, congenital malformation, and metal abnormality. Similarly, it involving 13-21, and what I have highlighted is involving 21-21. All the fetuses either will be monosomy 21 or trisomy 21, and hence all pregnancy will be abnormal in that case. So what will happen to future pregnancy in a balanced chromosomal translocation is abnormal outcome. If female is carrier, 5 to 10% is abnormal outcome. Male is a carrier, it is little less, that is 3 to 5%. What will be the outcome? It is same as that of previous pregnancy. If the previous pregnancy had resulted in abortion or malformation or mental abnormality, then the subsequent pregnancy might be same. And you can do a CBS or amniocentesis to identify that. But please remember, termination of pregnancy is warranted only if it is unbalanced. Please do not abort a balanced fetus. That is similar to that of one of the couple who is a carrier. So that will be normal. So next part of this thing is genetic cause. I have not highlighted anything because it contributes to very little and there is confusion in it. So inherited thrombophilias are the genetic causes of recurrent abortion, and that we know about is protein C(S) deficiency, antithrombin 2 mutation, factor V laden mutation. That if we exhaust all our armamentarium of diagnosing 50% cases of causes of recurrent spontaneous abortion, then we ventured onto these inherited thrombophilias, and those cases who has got history of thrombophilias or thrombosis, then we try to figure out if it is a case of thrombophilia, specifically Gulen, portal vein thrombosis. That case we try to figure out. This is one of the abstract that I got in British Journal of Hematology 2021, recurrent miscarriage and thrombophilia screening. And they did in 300 cases, 334 cases, and in their series they found in 8% cases. And they try to figure out if low molecular weight heparin will be helpful or not. Still, they are not very sure and hence not recommended. There is some study going on, randomized control trial, and that is known as ALIFE2 study, which is going on. Then factor V laden mutation, some meta-analysis suggests that the odds ratio of factor V laden mutation causing recurrent abortion is 2.1. So probably there is a cause-effect relationship. And if you do not find any cause, then probably you may go ahead and look for this factor V laden mutation. Prothrombin still is debatable. What Nature 2021 has identified is identification the cause of recurrent pregnancy loss in consanguineous couple using whole exome sequencing on the product of a miscarriage with no chromosomal abnormality. So once they have ruled out chromosomal abnormality, they try to find out if there is any genetic cause which we were like cross-talking in between. So I thought I will show this. This is a very recent article, and they have done in 12 cases. So they have found out some, say in around 11 cases, they have found some 6-7 genes. That is 11 genes responsible for it. And that is, but these are all experimental stage. Please do not carry this and advise this to your patient. These are all in research settings. You may put up a research proposal, but please do not advise the patient to do it. What I have seen that people advising whole exome sequencing from product of conception. This is a Nature article, then you can imagine what is the nature of this and the impact of this article must be. So hence, we still are in the experimental stage. So I acknowledge all my talk to my patients, all faculties and residents of the department, molecular laboratory, seniors and colleagues. I thank Dr. Tamkeen and the whole team of Prevention of Stillbirth Society of India. I always call it Prevention of Stillbirth Society. I don't like that Stillbirth Society. So this Prevention of Stillbirth Society of India, every one of you who have encouraged and thought that I should speak for this thing. Thank you all. And I will be.
So good evening, everyone. It's a small talk on antiphospholipid antibody syndrome. I will try to be as crisp as possible so that we can finish in time. So this antiphospholipid antibody syndrome is also known as sticky blood syndrome or a user syndrome that was described somewhere in 1980. It's a complex autoimmune disorder in which autoantibodies are produced against phospholipid and phospholipid binding proteins. They are actually prothrombotic. They interact with platelet membrane, phospholipids, increasing adhesions and aggregation of the platelet, and that can cause the intravascular thrombosis at multiple levels. So many terms are there for APS. Some terms are really confusing. I told you earlier it was Hughes syndrome. We don't use that. The commonest one is anticardiolipin syndrome. That also we don't use. We use antiphospholipid antibody syndrome. Another terminology was lupus anticoagulant syndrome, LA syndrome. Misleading term because patient with APS may not have SLE, and lupus anticoagulant is associated with thrombotic rather than hemorrhagic complications. Prevalence, if you try to see, of this particular APL syndrome is 3 to 6% in healthy non-pregnant patients, 2% in obstetric population in general, and 15% practically in those who have recurrent miscarriages. Classification, the older one, primary APS, secondary APS, familial APS, and catastrophic APS. Usually we don't use this particular terminology. We use that new terminology. They are the low-risk Kaplan syndrome. Low-risk Kaplan syndrome, when you get isolated anticardiolipid antibodies or beta-2 glycoprotein antibodies are seen, isolated one, but the quantity is less than 40 GPL. Hardly it causes any problem to the patient. Low risk. Then there is a medium risk and anti-APLA syndrome where anticardiolipin antibodies or beta-2 glycoprotein antibodies, they are present with more than 40 GPL units. And high risk we call when this is associated with lupus anticoagulant. LA is positive with all three, that is LA plus ACA plus beta-2 glycoprotein antibodies, all three are present. Then it becomes high risk, or LA plus either ACA or the beta-2 glycoprotein antibodies are there, then we call it as high risk. So high risk can be either 2 or 3 together, when they are present, and medium when it is more than 40 GPL. Pathology of this particular syndrome is it's a prothrombotic. It activates the complements, it activates the platelets, it activates the endothelial cells by the anticardiolipin beta 2 complex, seems to play major role in pathogenesis for causing lot of thrombotic events. Rest of the things are mentioned here. Thrombosis in uteroplacental vessels and placental trophoblast activity in it direct affects the placental trophoblast affecting the invasion of the trophoblast too. So many things it can cause. Clinical manifestation, if you see, either they can be asymptomatic, we call them carriers, less than 40 GPL. Classical APS, when you showed classical arterial or venous thrombosis, and those associated with recurrent pregnancy outcome or recurrent pregnancy loss. Otherwise, the patients are healthy. These are the three things what you see, and next two are important. APS with non-thrombotic effect, mild to moderate thrombocytopenia, hemolytic anemia, and livedo reticularis are the features of this APS with non-thrombotic effects. And there is a catastrophic APS, which is really dangerous one to be handled. Antiphospholipid antibody can also manifest as recurrent venous or arterial thrombosis. It can be associated with complications of pregnancy, that's the fetal loss, and it can be associated with characteristic lab abnormalities, which we are going to see eventually. APS is currently preferred term. Previous classification we don't use, but currently they have another classification, Antiphospholipid syndrome with or without associated with rheumatic disease. Other than this low risk, medium risk, and high risk, this is another classification, APS with or without associated rheumatic disease. Now it's a heterogeneous disorder. The clinical manifestation and antibodies are obviously varies with this syndrome. A revised criteria has been given for diagnosis of APS. At least one clinical criteria and one laboratory criteria must be present before you classify the APS. So clinical criteria are vascular thrombosis, or there are some pregnancy adverse events like death of normal fetus at more than 10 weeks, premature birth less than 34 weeks due to severe preeclampsia, more than 3 consecutive abortions at less than 10 weeks gestation, and obviously there is a placental insufficiency with less than 34 weeks. Lab criteria are anticardiolipin antibodies, IgG and IgM, both of them they are positive, more than 40 GPL. Anti-beta 2 glycoprotein antibodies, again IgG and IgM, more than 40 GPL, and presence of lupus anticoagulant. Lupus anticoagulant is not measured in any way, it's measured either positive or negative. So one clinical plus one laboratory criteria is mandatory as per Sydney revision to diagnose this APL syndrome. Vascular thrombosis is one of the most important events. The clinical episodes are either arterial or venous one or small vessel thrombosis in any tissue or any organ. It can involve cerebral, coronary, pulmonary, limbs, hepatic, renal, ocular, or adrenal. Thus, any circulation it can involve, and always can be confirmed either with imaging or Doppler or histopathological studies. Investigations are warranted if there is a DVT, if there is a pulmonary embolism, if there is acute ischemia, if there is a CVA episode, and obviously in young individual, in absence of other risk factors, we have to do a blood testing here. Pregnancy morbidity is really one of the important things here. One or more than 10 weeks spontaneous abortion, one or more premature birth of a morphologically healthy neonate before 34 weeks with severe preeclampsia and placental insufficiency, and 3 and more unexplained consecutive spontaneous abortions of less than 10 weeks of gestation. So we have seen the laboratory criteria, IgG, IgM antibodies, ACL, and obviously anti-beta 2 glycoprotein and positive lupus anticoagulants. Additionally, certain things they may be seen here, but we are not included in the criteria. Sydney modification have not included in the consensus statement. Cardiac wall disease, livedo reticularis, thrombocytopenia, nephropathy, and neurological manifestations may be there, but they are not included in the criteria. Suspect APL. If there is a thrombosis, if there is a miscarriage, if there is a cardiac valvular vegetations, if there are hematological abnormalities, if there is a nephropathy, non-thrombotic neurological symptoms, unexplained adrenal insufficiency, avascular necrosis of bone and pulmonary hypertension. So these are other clinical symptoms which may tell you that probably there could be APS. Etiology is obviously unknown. Possible trigger may be because of autoimmune or rheumatic diseases, maybe certain infections, and maybe certain drugs which can cause this APLA syndrome. So associated diseases are SLE, Jorgen syndrome, human T lymphocyte virus infection, rheumatoid arthritis, thrombocytopenic purpuras, hemolytic anemias, progressive systemic sclerosis, mixed connective tissue diseases, polymyalgial rheumatic disease, and obviously giant cell arthritis. Infections, we know there are so many, syphilis and so many others. And cardiac, you can see there are things. The drugs, they are procainamide, quinoline, and obviously there are certain antipsychotic drugs as well as amoxicillin even can cause the problem. Differential diagnosis can be either DIC or TTP or acquired thrombotic disorder, which you have to rule out. The hallmark that defines APL syndrome is the presence of antiphospholipid antibodies and abnormalities in phospholipid-dependent test of coagulation. So presence of LA in plasma of 2 or more occasions at least 12 weeks apart. Presence of moderate to high levels of anticardiolipin antibodies, more than 40 GPL units of IgG and IgM in serum plasma at 2 or more occasions at least 12 weeks apart. Presence of moderate to high levels of anti-beta 2 glycoprotein 1 antibodies, more than 99 percentile of 2 or more occasions at 12 weeks apart, and presence of LA in plasma on 2 or more occasions at 12 weeks apart. So ACL antibodies react primarily to the membrane of phospholipid. LA directs against the plasma coagulation molecules, result in paradoxical prolongation of clotting, coagulation assay. APS summary, if you see now, the following laboratory tests should be done. ACL antibodies, IgG, IgM, anti-beta 2 glycoprotein, again IgG, IgM, activated plasma prothrombin time, LA tests such as BR-BVT, serological tests for syphilis, CBC count, thrombocytopenia, and hemolytic anemia testing, and a low ANA level may be present and does not necessarily imply coexisting SLE in such patient. Infections like syphilis, TB, Q fever, Klebsiella, SCV infection, leprosy, and HIV may be associated. Malignancy, lymphoma, and paraproteinemia may also show false positive APLA test, and drug-induced phenothiazine, procainamide, quinidine, phenantoin, and hydrolazine may also show false positive test, which you have to check when you take history of the patient. When you treat this patient, you have 3 options. Either give low molecular weight heparin, you have to give the aspirin, and you have to give something like the warfarin. Warfarin can be used between 14 to 34 weeks of gestation, but you have to be very much cautious when you use warfarin because it can cause warfarin embryopathy. Early pregnancy loss, we have to give the patient either enoxaparin 40 mg subcutaneous, or you can give deltaparin, which is 5,000 units subcutaneous. It is late pregnancy loss, enoxaparin, you have to give 60 milligrams. Again, most important thing. The dose 40 and 60 milligram is also dependent upon weight, and it also depends upon whether it is an early pregnancy loss or it's a late pregnancy loss. Late pregnancy loss, the dose is more 60 mg. Early pregnancy loss, the dose is 40 milligrams subcutaneously. Additionally, aspirin 150 milligrams, corticosteroids has to be given to the patient of this. In ANC care, prenatal visits are every 2 weekly until 20 to 24 weeks, and every weekly after 24 weeks, you have to screen the patient for preeclampsia, do the uterine artery Doppler in 2nd trimester, and obviously you have to be very much vigilant in this patient not to have any complication like IUGR and oligohydramnias, which are secondary to the placental insufficiency. So serial ultrasound examinations every 2 weekly after 18 weeks, and every weekly NST and BPP testing after 32 weeks of gestation for checking the fetal well-being. Women with APS are usually induced at 37, 38, 39 weeks with continuous electronic fetal monitoring, and warfarin should be switched over to heparin at 34 weeks if the patient is on warfarin, and heparin should be stopped Once uterine contractions are noted, or elective when you are planning for induction 24 hours before either section, or elective induction of the labor, you have to stop it. Same thing here. Heparin can be resumed 4 to 6 hours after the vaginal delivery and 12 hours after the C-section. No specific neonatal complications are seen with APS other than IUGR and intrapartum fetal demise. Pregnancy outcomes, obviously, with low-dose aspirin, 44% improvement will be there. Corticosteroids plus low-dose aspirin, 75% improvement in the outcome. Low molecular weight heparin with low-dose aspirin, again 80 to 85% improvement is going to be there. And this is one of the promising things in Aps syndrome, that it can be treated if you are diagnosing it earlier and treating it meticulously. Postnatally, prophylaxis of low molecular weight heparin can be started 6 hours after vaginal delivery and 12 hours after the cesarean section. Please continue for at least 6 weeks postnatally. And that is what one of the most important things. Warfarin to be started with the help of the hematologist. Aspirin, we already discussed. Heparin, low molecular weight heparin is most important thing. It's the 3000 to 7000 daltons is the molecular weight. The one which commonly used enoxaparin is 4500 daltons is the molecular weight. That's the reason we call it as low molecular weight heparin. Has to be given subcutaneously for the longer bioavailability. And patient must be educated properly before you advise low molecular weight heparin. They should be trained how to take this particular drug. The fetal Warfarin syndrome, we all know if you start very early, hypoplasia of the nose and hand and bones problem and growth retardation can be there. In obstetric consideration, heparin is safe in pregnancy, preferred is LMWH. Warfarin between 16 to 34 weeks, ideally not 36. Heparin and warfarin are both safe in pregnancy in breastfeeding patient. No history of thrombosis. Start the prophylaxis. History of thrombosis, full anticoagulation has to be initiated. And this is what is the low molecular weight subcutaneous has to be given to the patient. Restarted after the 6 hours after the delivery. And catastrophic syndrome hardly we see is less than 1%. Widespread thrombosis and severe at several vascular beds is it's called as Usher-Son syndrome also. The patients are generally very, very ill. They do have active SLE also with catastrophic syndrome, Aps syndrome. And so many several vascular beds show widespread thrombosis. Intensive coagulation, plasma exchange, corticosteroids are to be given in this particular patient, and cyclophosphamide in selective cases when SLE is associated with catastrophic Aps syndromes. So in take-home message, due to wide spectrum of manifestation, any clinician may encounter patient with APS, so be vigilant. Potentially treatable condition, I do agree, may not be 100%, but yes, more than 85%. Best treatment at present to prevent the recurrent thrombosis is anticoagulation. Optimal duration and intensity is obviously controversial one. And this is all about the Aps syndrome.
Thank you so much, sir. On behalf of the Stillbirth Society of India, it is my proud privilege to propose a vote of thanks to all those people who have been instrumental in making this webinar of the RPL Committee a success. First and foremost, I would like to put on record our sincere gratitude to the Honorable Chairperson for today, Dr. Ravi Chandran, although he had to leave early due to the time difference. I'm also very grateful to our President, Dr. Neelam Agarwal, and our Vice President, Dr. Nuzhat Aziz, for helping and guiding us at every step. I would also like to thank Dr. Tamkeen Khan, the Secretary of the Society, for putting in all that extra effort. I wish to put on record my appreciation for our patrons, Dr. Evita Fernandez and Dr. Pratima Mittal, and all the members of our International and National Advisory Board for their encouragement and support. I am very grateful today to all the learned panelists and the speakers, Dr. Siddharth Das, Dr. Hemant Deshpande, Dr. Mandakini Pradhan, Dr. Minakshi Rohila, Dr. Chanchal, and Dr. Shelja, for so graciously sparing time for us and sharing their excellent input. I also take this opportunity to thank Dr. Shipra Kumar and Dr. Sujata for accepting the responsibility of the RPL committee despite their busy schedules. And finally, I would also like to thank our tech partners, Clarinet, for their logistic support, and appreciate and acknowledge all the members of the Stillbirth Society of India and all of the guests who have logged in today. Thank you very much once again, and hope you all have a great evening.